I do think that there is that kind of maternal guilt that we all have. And I think that one of the things that we really see is women blame themselves. So they blame themselves so much for their adverse pregnancy outcomes. It's one of the first things I say to women who experience, a preterm birth or a pregnancy loss, is that the first thing I say to them is, you have to not feel guilty, okay? I know that and most people kind of say, yes, I'm feeling really guilty. And I think we put so much pressure as a society now on women, birthing people to be that perfect incubators almost. And there's so much out there, isn't there? Eat the right thing and do the right thing. And, and if you do all these things right, then you'll have this perfect outcome. You and I, as obstetricians, both know that's just not the case.
Welcome to the Motherhood Clinic, a podcast about caring for mothers after childbirth, led by clinical experience and real-life stories. If you're a new mum and ever asked yourself, is what I'm going through normal? Should I be worried? Or who should I ask for help? This podcast is for you. It's for anyone navigating those early weeks, months, or even years after having a baby. Each episode brings together voices from across the motherhood journey, from clinicians, experts, and mothers from all walks of life. We're here to help you feel more empowered in your unique motherhood journey. We believe in a better start to motherhood.
So thank you so much. We have Susie Crowe today, and I have the pleasure of working with Susie. And so we're our colleagues, and I thought it would be amazing to have you on our podcast today. So thank you for being here today.
Oh, it's a pleasure. It's really nice to be here and chat about this stuff. It's great.
Oh, great. So basically, I know you have many hats. And one of your hats is you are involved nationally in terms of maternity care.
Mm-hmm.
And today we just really wanted to ask you some questions and your thoughts on postnatal care.
Yeah.
And so my first question was firstly, when we talk about postnatal care, what does that actually include?
Yeah, I think it's a really good question, because I think through birth, in the preparations we have for birth, there's so much focus, isn't there, on pregnancy, and even before women get pregnant, there's so much information out there on social media, etc., about the pregnancy and making sure that we're kind of ready for pregnancy and the changes that happen in pregnancy, and there's a lot of focus on birth. And then I think there is so little out there around the postnatal period, and in particular around the kind of changes that happen to women's bodies postnatally, because all those changes that have happened, the changes that happen particularly at the beginning of pregnancy, in that first trimester when our bodies are getting ready to carry a baby and to birth. There's significant numbers of changes that happen in that time, and all those changes have to reverse again, and I think that we forget about that. We forget that there's all these huge changes, so I think that there is, so that the postnatal period full stop, I think, has just not had enough resource or thought put into it, I think, even from a societal perspective, let alone anything else. And similarly, I think that one of the things that we see is that, again, we have a huge amount of resource looking at the way in which we are supporting women antenatally and through birth. But in terms of postnatal care, I think that actually there is quite a lot of variation around the country, and that I think can be actually potentially quite patchy. So the very standard things that will happen is that after a woman has had her baby, then she will stay for a certain amount of time postnatally in the hospital. If they've had a straightforward vaginal birth in a midwifery-led setting, women often may go home even after just 6 hours, but compared to having a cesarean or more complicated birth, where they may still stay for longer, and they'll be looked after in the postnatal ward on a hospital for a day or two, sometimes longer, and they'll be looked after by majority midwives, sometimes nurses, sometimes doctors as well, and then when women go home, they're there under the care of the community midwifery teams, and community midwives will come out, but they come out for a relatively short period of time before that's handed over to health visitors. And then the other thing that every woman should be going to is their check then with the GP, where the GP will then check over the mum's health and the baby's health. I think, again, what we found is obviously GPs are doing an absolutely brilliant job in it, but, you know, their time is really, you know, it's an awful lot to fit in to quite a short appointment time. And, you know, we're asking GPs to do more and more and more with less and less resource as well. And I think that women understandably go to those appointments are often thinking that that there's a big focus on the baby and checking the baby's development, etc. But actually, we really should be looking at the maternal health as well and how the mum's recovering.
Yeah, no, I think you've summarised that so well. And I guess we'd just say that the handover of care, the end of postnatal care, would be at the handover to the GP around about that 6-week mark.
Yeah, I mean, often the care has been transferred, you know, a bit sooner than that. I think, again, it depends how hospitals set things up, really. So some hospitals do have postnatal clinics where they'll see women who've had complexities in their pregnancy, or like the clinic that you and I both do at Whips Cross, where actually we have got a really good setup, I think, at Whips, where any woman who's had for example, high blood pressure in pregnancy and needs to make sure we follow that up and keep her safe postnatally. But, you know, women who might have infections or even have had a complicated time postnatally, you know, at Whips, they'll be seen by a consultant obstetrician like you or me, and we have really good half-hour appointments. And I have to say, I love seeing the postnatal women in that appointment. They're some of my favourite appointments because it's really nice to be able to talk to somebody kind of holistically about their kind of journey into motherhood, and kind of have a bit of a debrief sometimes about the birth, just, you know, not kind of full debrief, but at least kind of be able to, they can ask questions, but also being able to support them kind of, you know, to be able to answer questions about breastfeeding, you know, and kind of see them as a full person, you know, and look after them too. But I think things like that, you know, don't exist in every hospital. And I think that one of the things is that it's to do with the way that we fund maternity care. And I think I really don't think the funding packet for maternity care actually really covers really what we need to really provide really good maternity care for all the women that we're looking after now in the UK, and making sure that we're reducing inequities and looking after everything that they need, and the postnatal care. And I think postnatal care is often the thing that slips. So I think that sometimes women will have been transferred over to their GPs a bit sooner than that as well. But I think it's quite variable.
Yeah, no, that's so interesting because that's like where we work, we are able to offer that service. How does because from a national perspective, how does the postnatal care vary, and how can it vary, especially for those who don't know, in terms of if we say, depending on where someone lives, what do you feel is the postnatal care that is offered across the UK or England?
Yeah, so there is standardised guidance. There is nice guidance that's particularly around midwifery care for postnatal care. So so most hospitals will be following the nice guidance in terms of when women go home from hospitals, the care will transfer to the local community midwives who work in the area where that woman lives. So, for example, for a big metropolitan place like London, where women may choose to birth in a unit that's not the one that's right next door to them. You know, in London, people have huge amounts of choice about where they have their baby. I mean, that's obviously not the case in lots of places around the country. Lots of places, you know, particularly more rural places, or the rural or the places on the coast, you know, people will just be going to that one place. But, you know, so say, for example, in London, you know, where one woman in one area might have a choice of 5 maternity units. So she might choose to go to one a bit further away, but the care of her postnatally will transfer to the community midwives who are based in her local hospital. So you need to rely on kind of good communication between the two hospitals and that community midwifery team taking over. So I think all NHS services will be offering that standardized care in terms of those postnatal visits that midwives will be offering and coming out to women's houses, and when they come out, they'll be obviously there'll be a focus on the baby as well. So they'll be looking at how the baby's feeding, and they weigh the baby, and they're looking to make sure the baby's regaining the baby's birth weight. But, they'll also be asking the woman questions about her own health and things like the blood flow, if she's recovering from a cesarean birth, checking the wound, asking questions about medication, looking at women's blood pressure. That's a really important part of what they do as well. And they also screen for mental health conditions as well. So they'll also be asking women about how they're feeling and looking for things like postnatal depression and postpartum psychosis, which is a rare thing, but these things can happen as well. So I think that's the standard offer that everybody gets. I think where the variation particularly lies is around the kind of medical input around women for postnatal care. And I think that one of the reasons for that is that it's often been seen as the kind of, like, we quite often describe it as like the Cinderella service, which is really sad. But I think it's, the focus has always been on the kind of keeping women and babies safe during pregnancy and the birth. And I think what we've often done is then really neglected as doctors our input into postnatal care. And I don't mean that for us as individual doctors. I think, people like you and me would care deeply about our women. And, and as I said, I love following up women, and I love providing that continuity. But it's just how the funding works. So, I think, as an example, traditionally, if you were an inpatient in hospital before you have your baby, you'll be highly likely to be seen by a consultant, and at the very minimum, a registrar, so a doctor who's been working in obstetrics and gynecology for quite a long time. Yet those women get transferred to the postnatal ward, and often it's our resident doctors who may only have been working in obs and gynae for a short amount of time or not been doctors for as long. And I think it's things like that. So it's around how do we make sure that we are promoting and making sure that we've got good senior input into women postnatally too. And similarly, I think there's a lot of variation in the way things like postnatal clinics, for example, are funded, and whether or not services run postnatal services as well.
Okay. No, that's so true. It's a great picture that you painted. And I guess that's the standard offerings everywhere. So with postnatal clinics, is that basically decided based on the individual trust, whether or not they will fund a postnatal clinic that's obstetrician led?
Yeah, I think it is, and I think a lot of the kind of any of the good work that's being done around this is actually often generated by obstetricians with an interest. So I can certainly point to a few obstetricians that there used to be, I don't know if it still exists anymore, but for a little while, a postnatal leads obstetric group that kind of got together, and I know they had a WhatsApp group, and and had some meetings, etc. as well, and and a lot of that was driven by a couple of obstetricians who kind of really are really passionate and really kind of developed a really strong interest in postnatal care. But I think there is probably quite a big postcode lottery with it, as these things are. So if I think about a service that has done a huge amount of work around postnatal care, and done brilliant stuff around information giving for women, and and really working with service users, and the service users in the area to kind of, for example, connect women who've had maybe kind of rare experiences through pregnancy, and want to connect with another woman who's gone through something similar. A service like that was come out of something like Chelsea and Westminster. Chelsea and Westminster, is quite a unique trust because it's in West London, it's in an area of affluence, and I think that we think that the NHS is the same wherever you go, but it's really not. And trusts like Chelsea and Westminster will generate an awful lot of income because it's got a big private hospital within it and lots of research. And that in itself generates income from the trust, which means that they can then invest even more in maternity services compared to trusts in areas of social deprivation. So that means that they'll have had the ability to develop those services because of that additional investment over and above the funding that you would get from the government for those services. So I think that what that has then done is that there are lots of people out there that are really passionate about it, but it's about trying to advocate in that space, and for us as doctors to recognise the importance of us as obstetricians working in postnatal care, not just in antenatal care and birth as well.
So I guess what you're saying is like it's come from passionate obstetricians and areas where it's possible to have these additional services. And it's not quite standardized. I guess that's a dream.
I think it is. So one of the things that we've done actually recently at NHS England, which will publish soon actually, is that we have developed it's called a suite of role descriptors. I don't get too technical about it, but essentially kind of providing some standardization around some leadership roles that obstetricians might undertake. So, as obstetricians, we'll all work clinically and we'll all have areas of different clinical interests, for example. And so, so you might have some obstetricians whose interest is in scanning babies, and others whose interest is in looking after women with diabetes, like the service you run, for example. What we wanted to do through that was provide some standardization so that people would have a framework, and trusts could really help to actually fight a bit more for some of these roles. And one of the roles we've put in there is a lead for postnatal services for every maternity unit in the country, in the hope that actually people will be able to use this as a way to fight for these jobs. And that's my aspiration, is that they can then do that. But it's really interesting, again, just kind of going back to that Cinderella service, because what we found when we were trialing this and working with trusts around the country to recruiting new doctors or extra doctors or give people these additional leadership roles, was that everybody focused on all of the other roles first.
Right.
And often
that's the last role.
It's the last role they put in. Yeah. And it's often, I heard it said all the time, it's because people say, oh, it's because the other roles are crucial for patient safety. But actually, these roles are really crucial for patient safety as well, and in particular, if we look at, maternal mortality, which thankfully we know in the UK is really rare, and we've got a really safe maternity service in the UK, so women and babies don't die in the same way as they might do in other parts of the world. But one of the reasons that we know that women can die in pregnancy or in pregnancy around pregnancy in the postnatal period is particularly around getting clots in their legs. And there's effective treatment that you can give to help to prevent that. But you need people to recognise it and talk to women and make sure women understand why it is they're taking this medication. It's really important. And then the other thing is the risk of suicide as well, postnatally. And again, that's another reason that we really need, really good services to look after women's mental health as well.
Well, it's quite striking that that's a time frame whereby women are most vulnerable and at risk of these complications, although rare, and yet we don't emphasize the importance of that and have the appropriate staffing in those areas and roles. I guess it's going to have to be a really big shift in mindset. But that sounds amazing. It sounds really exciting that hopefully the role descriptors and trying to make it more standardized across the UK would be a really good start.
I really hope so. And, and within that role descriptive, we've really described what it is that we think that, people should be doing in that job as well. So that's what this document describes. So, it describes, providing leadership in postnatal care, making sure that actually women do get to be seen by by, sometimes a more senior doctor if needs be. I mean, that's not to denigrate our resident doctors who are all trained very well and are good at seeing, often women who've had more straightforward births. But I think that, one of the things that we know that we're seeing quite a lot of is women with birth trauma, and sometimes the need for them to have a good debrief, or just understand what's happened in their birth. You and I both know, and lots of women who had a baby can know, that birth can be unpredictable, and things that you thought you might hope might happen don't necessarily happen, and things can happen very, very quickly. And sometimes when you're in the middle of it, and when you're in the middle of labour and you haven't slept properly, it can be frightening, and it can also mean that you weren't necessarily fully aware of what was going on. And having the ability to actually have a conversation with somebody about that, who is an expert in birth, who really understands and can really explain it to you well, I think is actually really important, as well as thinking about, the more complex things. So the women, for example, who have, experienced complexities or in their pregnancy or their birth, or women, for example, who might have gone into pregnancy with other medical conditions and have had a more high risk pregnancy as a result of that. And actually, we also need to think about how their bodies then adapt to the postnatal period, and thinking about it from that perspective as well. So yeah, I think that one of the issues has been that I think probably our previous model has always been, well, it's a bit like we just described, well, it's okay, we've now had the baby, now as obstetricians we can step back because we know that, we're handing them over to GPs. But as I said, the job of a GP, I think, has changed dramatically over the last 20 years, and GPs are managing more and more chronic illness. They're managing, people with a myriad of different health conditions. We've got an aging population, and the demands on their time are absolutely huge. And I think that's where we really should be stepping in, actually.
No, that's really interesting. And going back to a birth debrief, and you've mentioned how it might be helpful. What do you think it really should involve? And do you think it's how would it be helpful to carry that out by an obstetrician and midwives together?
Yeah, I think it's really interesting. I think that, and I think there's a lot of talk about this at the moment. I think a lot of services have got debrief services these days. I think that it's variable who delivers it. I think quite often it's delivered by a consultant midwife. So that's, a senior midwife with who works kind of, consultant midwives usually work 50% clinically and 50% in kind of leadership and management, that kind of thing. But again, and I think that one of the reasons that we haven't necessarily funded obstetricians to do it in the same way is because we're really expensive. And our time is, and it's one of those things that, people just have kind of put under the table almost. So it's just, or put it into the kind of too difficult, or, we can't, well, that's a nice to have sort of thing. I personally think that if a woman has had I think we should be getting better personally at, as I said, ensuring, I think, that women, before they leave the hospital, have the opportunity to ask questions about their birth and really have an understanding about what happened. As I said, I can remember actually from when one of my own babies was born, and in my head, there was a scenario about how something that unfolded in kind of a few hours after I had him, and it was only a couple of years later that my husband said, "No, that's really not true."
Oh my goodness!
Yeah.
A few years later,
that's not what happens at all. But obviously, I think and I'm an obstetrician. I'm quite in hospitals. I know what it's like to have a baby, but my memory of it was completely different, because you have just had a baby and, hadn't slept and, and all of those things. And so, and I think that probably when we were first training, in hospitals, I think that the way that the medical training was structured, and because of the hours that we worked, we were there all the time. You know, and you know, we you know, you work 5 days a week, so often there was the opportunity for the doctor who might have delivered your baby to go back and see you, and certainly that was always my own clinical practice. You know, I would always go back, and actually I still do because
That's amazing.
that's what I do. You know, even if it's at the end of the shift and I have to, and I can't really go back the next day, I will always go back to somebody and say goodbye, and I'm leaving. But, you know, if you want to, you know, this is my name, and if, you know, if you've got any questions or anything, you know, but I think, you know, that these things just take, that's quite a lot extra that people do, and we don't have that infrastructure. So I think the first thing that could actually debrief could actually come in with actually making sure that if women have got questions about that is particularly not just, you know, not a midwifery thing, but, you know, a medical intervention thing, then us having the ability to be able to answer some of those questions. And I think that would be that infrastructure, we could create that much better if we invested in doctors having more input into the postnatal wards as well. So I think there's that bit, and then there's obviously there's the kind of, then there's what we might call a bigger debrief. And so sometimes women come through postnatal clinics, for example,
if they exist.
You know, again, our service actually has a postnatal anaesthetic service, doesn't it? So women who had, you know, complexities around their anaesthetic, maybe epidural's not working properly, or women who might have ended up on an intensive care unit or something, which can be very frightening for women. You know, so again, our service, I think, you know, we've got a really lovely consultant anaesthetist who runs that service. But again, I think what would be great actually is if we can make those services all really joined up. So actually have maybe an anaesthetist, a midwife, and an obstetrician all having, you know, doing it at the running clinics at the same time, so you can have that input with each other. I mean, that's probably
I think
pie in the sky.
I've been doing that at Whips.
Yeah.
Yes, I think it is quite hard to do, because I wonder if you know of other units that are doing that, but I do try to combine them. But I just wonder what the national offerings are. It's probably less likely for that to happen.
Yeah,
for so many reasons.
I think exactly. You know, things like estates, getting people into the rooms together, you know, or clinics together, etc., etc. So yeah, exactly. I do think that Whips actually, I think we probably do quite a good job in some areas of our postnatal care. Actually, I don't know if that's because that, you know, many of us have experienced postnatal care. Probably help to drive some of those things. I think that we sometimes we don't talk often enough, I think, about how we as doctors or midwives actually are service users sometimes as well.
That makes a big difference.
And it does make a big difference. And many of us will experience things through our own pregnancies and birth experiences and postnatal experiences that sometimes gives us a new drive because we've seen it with fresh eyes, or to try and make it better or make it more equitable, you know. Or in my case, you know, some of the things that I knew that I could advocate for myself, I want other women to have that as well, you know. So I think that's variable. I think one of the interesting things about debriefs, you know, people talk about then a kind of longer term debrief, is whether or not actually if you're starting to get into the more kind of psychological debrief side of it, is whether or not we as obstetricians and midwives are actually best placed to do that. And actually, if we should really be supporting kind of better psychological debrief, actually with psychologists. And again, some services offer that, some don't. You know, for example, there are often, or usually, psychologists, I think these days, working within neonatal intensive care units that provide psychological support to parents of babies going through NICUs. But it's, you know, trying to get those services in. So we're not just thinking about outcomes for babies, we're really thinking about the impact of birth on women as well. Because I think that's really important. We have such a massive focus on babies, but actually, you know, if a woman's has bled a lot at birth, it can be very frightening and quite psychologically damaging, or if a woman goes to an intensive care unit as well. But it's also recognising what it is that causes birth trauma too. And I think that, you and I have looked after enough women and, dealt with enough women who have quite rightly complained sometimes about their experience in their care. And actually, we know that it's not necessarily the birth that they experienced, it's often the way that they were spoken to and how much they felt listened to and whether or not they felt supported. And that, I'm sure you've seen that as well.
100%. And I think often it's like what's written on paper.
Yeah.
It's been a normal birth or something like that.
Yeah.
And that doesn't translate to the impact that it may have on the person and their family.
Yeah.
Sometimes I find we often neglect the birthing partner. I don't know if you feel that way too.
Yeah.
But no, it feels like the ultimate birth debrief would be having like a whole umbrella of all these professionals and tailored to that individual.
Yeah, exactly. Because it can vary, can't it? We might look after, I looked after a woman recently, for example, who had a condition called placenta previa, so was at high risk of bleeding. Sometimes, that's when the placenta is low and sometimes they can bleed. And she came into us by ambulance having lost huge amounts of blood. And we had to, we had to kind of work really quickly to save her and her baby's life. And she was fine and her baby was fine, and the team were absolutely brilliant. And actually, when I spoke to her, she wasn't particularly traumatized by it, actually, because she said as soon as she came in, she felt safe. The ambulance came very quickly. The ambulance came, the paramedics looked after her. She felt very safe. She felt that she knew that she was in safe hands and people had cared for her and everything was okay. But her poor partner, who was left at home looking after their existing child, having seen a massive bleeding, their partner, having this big bleed at home, recognizing what it's like, and then going off in an ambulance and not knowing what was going on because they were stuck at home, was really traumatized. Understandably, actually, and again, it's really interesting, isn't it? Because somebody might say, oh, well, actually, or we might assume that everyone who has a big hemorrhage might be traumatized, but actually sometimes they're not. And similarly, a woman on paper who's had a quick vaginal birth, people will say, well, you're really lucky. Oh, that was amazing. Oh, you're really lucky. You've had a, really quick birth. But, for some women, women have very, very fast labours. It can be really frightening. And in particular, if they might have, if they haven't felt listened to, or if it's been so quick that their staff haven't been able to get to them quickly enough, or that they've been trying to kind of get get people in, or they don't understand, they don't know what's happening to their body quite so quickly. That can be a very, very traumatizing birth. And I think that what we forget about birth and actually being pregnant is that I think that our hormones when we're pregnant kind of give us a really protective instinct over our babies and our bodies. And I think that we have a real drive to just want to protect our baby. And I think that makes us, I think that anything that therefore kind of thinks that your particular baby's life is in any way in danger, and yours potentially as well, I think it's probably more traumatizing than actually when you're experiencing other bits of healthcare. So again, how we respond, how women feel, how safe women feel, the things that women say. I think you're just very vulnerable, aren't you, when you're having a baby, and particularly postnatally as well. And I think the things that people can say to you postnatally can have a massive impact. So I think
such an interesting take.
Yeah, but I think well, you and I will have seen women, haven't we? That that will have come through, and we'll talk about sometimes some of the things that have been said to them, particularly around how women have had their babies. There's so much public discourse, you know. I don't know, there seems to be any right way to have a baby at the moment.
I know. Yeah. I guess it's just how we can make them feel. And I guess sometimes when we get to that stage where it's the postnatal part, we may not be able to undo things that have happened, but we can help them like just understand it a bit better. So I'm guessing that's what you mean by a good birth debrief, and trying to get in there ideally by the person who's delivered. And I know what you're saying. It's so amazing that you try to see the women that you've delivered. And in this day and age, a lot of resident doctors and consultants, they work on a shift basis.
Exactly. Yeah.
So they're not.
It's really hard
to be there.
No, it's actually, you know. So you
go above and beyond.
I probably, but I think it's something that was just probably just ingrained in me. But I can't always go back to everybody. You know, I actually I do my cesarean list on a Friday. I'm not in a hospital on a Saturday. So, you know, I will always go back, and before I leave the hospital, I'll always go back and say goodbye and just ask people if they've got any questions at that point. But actually, you know, as you said, we shouldn't. This is something that I do, I think, through my own goodwill, and we can't. The NHS has relied too long on goodwill. You know? we can't be expecting all doctors, you know, to be doing things over and above their contracted hours.
So it's really, you know, built into the system.
Yeah, exactly. And I suppose one of the reasons that I can do that is because of the way that I do my clinical work, and because I do my other jobs as well. I suppose I have a degree of flexibility as well, whereas a lot of other doctors, exactly as you said, you know, might not be able to go back, not because you don't want to, but actually because you've just got a really full clinic seeing lots of other patients that afternoon as well. You know, the clinical demands are so high. So it's about recognising that we have to build that. Build that into the system. So yeah, I think there's that. So there's the actually, this is what happened, this is why it happened. It happened, explain to women, you know, and giving them the opportunity to ask questions about their births. And as I said, then I think if you are, you know, but if you have got PTSD, then I think that's a slightly different thing, and that's more kind of psychological input as well. I think one of the other really interesting things is around looking at women with bereavement. And again, you know, thinking about, you know, having really good bereavement services, and making sure that's kind of done well. And I think that there's been a lot of improvements in the NHS around that. There's a national bereavement pathway. Again, you know, you and I both work with amazing bereavement midwives, don't we?
Yeah.
And our colleague who runs the bereavement service as well. So I think we've got better at looking after some of those women. I think that certainly all the things that are coming through at the moment from people talking about lots of the campaigns around maternity and maternity safety are families who've sadly had really awful times experiencing avoidable harm or potentially avoidable harm in maternity services, and then felt that they have then had that harm compounded by the way in which maternity services have responded to them. And again, I think that we need to get better at thinking about the pathways for these families, and again, making sure that we've got the infrastructure to ensure that they can ask questions, that they can see people, and that again, that they feel as though the hospital is looking after them.
Yes.
And if there are lessons to be learned, are going to learn it, because actually that's what most people want from it.
So, and if, say, in these circumstances and outside of that too, how do you think the lack of postnatal support might affect how they feel in a future pregnancy? I think it's got a big impact.
I think it does. Yeah, I think it does. I think that we, I think that people, you know, go into them with their future pregnancy. You know, if you've experienced trauma, then that will obviously affect the next pregnancy. You can experience something that is potentially traumatic, but actually your experience of it having trauma is a slightly different thing, and I think and actually that's one of the reasons that we need services to be trauma informed so that we recognize that, and we recognize that a pregnancy after something traumatic has happened or somebody's experienced a loss is going to be a very different pregnancy for them. So similarly, you and I will have looked after women who've had, stillbirths, for example, or preterm births in their previous pregnancy, and particularly if we've not managed to find a reason for it, that can be really, really hard for women and their partners as well. That pressure that, and I think what women often feel, I think we all feel parental guilt, and I'm not going to just say it's a woman's thing, but I do think that there is that kind of maternal guilt that we all have, and I think that one of the things that we really see is women blame themselves. So they blame themselves so much for their adverse pregnancy outcomes. It's one of the first things I say to women who experience, a preterm birth or a pregnancy loss, is that the first thing I say to them is, you have to not feel guilty. Okay. I know that and most people kind of say, yes, I'm feeling really guilty. And I think we put so much pressure as a society now on women, birthing people to be that perfect incubators almost. And there's so much out there, isn't there? Eat the right thing and do the right thing, and and if you do all these things right, then you'll have this perfect outcome. You and I as obstetricians both know that's just not the case, and we for all the reasons. But I think that guilt is also something that women carry with them as well. And I think that can be really hard. And so I think it's about being trauma informed and recognizing that as well. And I think that some of that trauma and that damage might have happened around birth, but actually I think it could have been ameliorated or made better in the postnatal period too.
That's so true. And I guess sometimes you might not be ready to process that immediately after birth. And so that's why I feel maybe the postnatal support needs to be extended a bit longer.
Yeah.
And as you say, not everybody is, although we may, the postnatal period ends a little bit sooner, depending on where you are, and just how we can tailor that to the needs of the individual.
Yeah.
And maybe it's beyond that 6-week mark, whereby they would see their GP for the first time.
Yeah, it is. And I think it's also recognizing that, that actually, really the postnatal period, certainly doesn't stop at 6 or 8 weeks, does it? It really doesn't. All those changes that happen through pregnancy, it can take a really long time for those changes to reverse, and also, and in particular, if women are breastfeeding as well, that's still quite a significant shift that's going on in your body and all those hormones as well. But things like the hair loss that women experience after a baby, that happens quite a few months after having a baby, doesn't it? Or just being able to get back to, postnatal to fitness again, it can take quite a long time. And I think I think our bodies often, they don't go back to how they were before.
100%. Definitely. From personal perspective.
No, exactly.
Yeah.
They don't go back to how they were before, but I think society's kind of expecting that almost, isn't it? I know there's lots of things these days on social media about it, but that kind of expectation that we're kind of back to normality. And as I said, the hormones of pregnancy and then of lactation, hormones are really psychoactive, so they affect our brain processing. There's all sorts of things, so I think most women don't really feel like they're often back to towards how they felt before pregnancy till often a good year or so. after they've had a baby.
No, and I am so passionate about that 1 year after birth. Just that's such a good opportunity, and I really like how you've called it, like how you have to reverse all those changes, and it just feels much more easier as a process in terms of allowing yourself that time.
Yeah.
And yes, because so much has changed. So
Yeah.
you physically feel it, you feel it emotionally as well. So yes, I agree with you. I think we're just so programmed to say 6-week postnatal check.
Yeah.
But maybe you're right. And it should be more like that whole 4th trimester and beyond for that 1 year to just reverse the changes.
Absolutely. And also, so your body has, a woman's body has just been through this like incredible thing. You're growing a baby.
Yeah.
It's just, it's remarkable, really, isn't it? And I've been an obstetrician for over 20 years. And I still think birth is amazing, and I still,
You found the right vocation.
I did, I really did. And I really do. And I still, every time I deliver a placenta, I just think, oh God, this is amazing, isn't it? We have, it's remarkable what physiology does. We have, when you're pregnant, you expand your blood volume, you have 750 mils of blood every minute going through your uterus into the placenta, and then you deliver the placenta. This entire organ has been developed just to grow and develop this baby, and then it just comes out, and all of this blood flow that's been going through the uterus clamps down and stops it. I mean, I genuinely think physiologically it is amazing, and we don't talk enough about it.
We should have a whole podcast on that.
I should, yeah, exactly. But that's huge in all of those changes, and that's not even thinking about. Actually, we're becoming, often if it's your first baby, you're becoming a mother or a father, or a birthing person for the first time, aren't you? And that, that big shift that happens, and it's not just your first baby; it's with each, with any baby that you then have. And I think that we've lost that. I think somewhere in the middle of this kind of. I think this focus, a big focus on birth, and I think a big focus on babies. And so I think, the feminist in me is very much about thinking about how we support women. And I suppose the other thing, just thinking about as well, is again, how to maintain health and maintain a healthy lifestyle postnatally as well. Because I think that, again, what we're not very good at doing is supporting women to get back to being active, back to sport. And I think there's a lot of things that we're just not very good at describing to women and supporting that. So I think it's really sad, actually, that you often see women in their 20s and 30s who've been athletic or done loads of sport, and then they have a baby, and then for whatever reason they then aren't able to go back to it, and they can normalise that, if that makes sense. And I think some of that is around pelvic health, and that women often don't know that they, a significant number of women will have urinary incontinence after pregnancy and births, which can last quite a long time, and it, that can really affect women, and often it will get better. It usually does get better. Obviously, there are some women who it doesn't, that need more specialist input. But again, we need women to be able to access, really good pelvic health. Good, really good pelvic physiotherapy can make massive differences to women, and it also then means that women then get, back to exercise quicker. And I'm not saying that from a kind of, because I think women should have a perfect body and it's about aesthetics or anything like that. It's just about, supporting women's longer term health, and the benefit of exercise on their, their bone density, their long term cardiovascular health, etc. as well. And I think that this is where lots of the inequities sit, because affluent women, there are companies literally, called things like Mummy's MOT, I think, and women can all afford to go to private physiotherapy, or, you know, like I did after all my babies. I say all, I don't remember that loads, isn't it? I had three babies. I did postnatal Pilates, with, you know, and really good courses after each of them. I'm actually not passionate about a lot of things, but I'm really passionate about actually supporting women to kind of get their core back.
Yes.
Because of the changes of pregnancy. And, you know, you have that diastasis recti where your rectus muscle separates a bit. And actually, if you you know, really good kind of pelvic floor and core, but, you know, done in a way that understands the changes that are happening to women, can be really, really valuable. I think one of the reasons that we see quite a lot of women in later life with lower back pain and pelvic pain, it's actually referred pain from the back, because they haven't managed to re-strengthen their core again. But again, affluent women can afford it, but it shouldn't just be about affluent women. It should be about all women, really, shouldn't it?
Yeah, no, definitely. And I think that's a very important topic as
Yeah.
well, that we can address separately. So no, there's some really great thoughts today. And I guess if we were to wrap it up, in terms of, if you were to say one main message that you would want to give to women about postnatal care and postnatal support and what they should ask for, what would you say it would be?
So I think it's really important that in the midst of motherhood or parenthood, when everything is about the focus of your baby, and we have so much focus on the baby, don't we? Understandably, I think that thing that we say, where self-care isn't selfish, is a really important thing, actually, because for us to be able to look after our children, actually we want to be the best versions of ourselves as well. And actually to put yourself, you know, to put yourself up there as well. First is a difficult thing to say. I don't think, you know, when you've got a small baby, you can't put yourself first. I do remember what it's like, but actually making sure that you can prioritize thinking about you and looking after you and your own health, I think, for me, is actually one of the most important things. And that's not just your physical health, but your mental health as well. But yeah, and I suppose the last thing would be, if you have had a traumatic birth or find things that there were things that you have questions about, please do. Most services, I think, do have some form of debrief, or birth reflections, etc. So please do get in touch with your local hospital.
Okay. No, thank you so much. That's really, really helpful, and lots of food for thought. So,
Pleasure.
thank you.
Thank you.